Hi everybody, welcome to part 3 on our challenging splenic lesion lecture. We left off last time talking about splenosis. We looked at accessory spleens, and we made the point that usually we can make the diagnosis, but it's not always the case. This article by Ba, 10 patients out of 303 patients who underwent a distal pancreatectomy were identified with the final path of splenic tissue and not what was suspected, which was a neuroendocrine tumor. Lesions were described as round, well marginated, and enhancing within the tail of the pancreas. Pre-op workup was variable in terms of imaging and lab testing. Diagnostic workups were examined and combined with multidisciplinary input to create a diagnostic algorithm. So this article does make the point that it can be challenging. Here's a good example. There's an accessory spleen. This was initially sent to us as a patient who should get a distal pancreatectomy for a neuroendocrine tumor. You could see that its enhancement is similar to the spleen. Its texture is similar to the spleen. You could see it very nicely on the coronal views as well. There it is, and here. And you could see it was concerning because it was on the undersurface, which is a good location for accessory spleens, but just it was further back, and the initial interpretation was that this was a neuroendocrine tumor. Here it is nicely shown in the cinematic. But again, you could imagine where this could be confused. We weren't sure. We got a nuke study, and there it is, a pickup on the nuke scan. So this was an accessory spleen, and nothing else needed to be done. Now, I mentioned that accessory spleens enhance, but like the spleen. Here's an enhancing lesion in the tail of the pancreas, and you say, wait a second, this must be a splenule because it's enhancing. But the spleen is enhancing with a moire pattern. This is more vascular, and when you follow it out, as you go to other images, you can see it's more vascular than the spleen is. And there's also a faint calcification. Faint calcification helps you out a lot. But again, it's brighter than the spleen. This is not an accessory spleen. This is going to be a neuroendocrine tumor. And here it is very nicely on the MIP imaging as well. And very nicely also shown on the cinematic rendering. You can see here the texture is different than the texture of the spleen. Again, a very important finding. As I've shown you some cases of the spleen and splenules with cinematic rendering, you could see one of the things we always speak about in the spleen or any organ with cinematic rendering is textural mapping. And you can see from these splenules that can indeed be very, very helpful. I mentioned before wandering spleen due to either acquired or congenital laxity of the splenic suppensatory ligament. And you could see there's this article by Nelson, again, making the point, a wandering spleen appears as an enlarged spleniform mass in an ectopic location with partial or complete absence of parenchymal enhancement. And in some cases, the twisted vascular supply may be evidence as a whorl sign with alternating opaque and lucent bands. Here's a great example. This patient had right lower quadrant pain. The thought was appendicitis. What is this mass we're looking at here? Well, this whole mass is the spleen. Now, of course, if you were scanning the patient, you would have recognized the spleen was not there, and so it makes it a bit easier, but you can see there's the splenic artery coming down. There's the spleen, and there's the splenic infarct. It's a really nice example of a wandering spleen with partial infarction of the spleen. Patient had to undergo a splenectomy, but you can see why it was really an interesting case. Again, this is unusual. Sometimes it could be a post-op complication, but usually it's just a very, very long suspensatory ligament. And this can happen every once in a while. Here's another example with back pain. The first thing you recognize is the stomach is well distended, but there's no spleen. The patient never had a splenectomy. Well, maybe the patient has asplenia. Maybe the patient does not have a spleen. But as you scan further down, there's this big mass in the pelvis, but it's not really enhancing. there's a twist in the mesenteric vessels. That mass in the pelvis is really a globally infarcted spleen. It's a really nice example. You could see why you just don't think about it unless you've seen some cases before. It can be really challenging. A really nice example of a globally infarcted spleen in the pelvis, your wandering spleen. Now let's look at some splenic lesions. Let's start off with some benign lesions. And again, the big three are cysts, hemangiomas, and hamartomas. Cysts are typically water density. They can be small or they can be large. They typically don't lead to anything. They're never premalignant. You rarely have the history of a splenic rupture due to a cyst. I guess theoretically with trauma, you might be more likely to rupture a spleen if you have a big cyst present than if you have a normal spleen. I guess that's possible. They can be very large. They can simulate pseudocysts, as in this case coming from the spleen proper. They can simulate retroperitoneal masses. But when you start looking at the entire process, you recognize that it's a spleen, and in this case was an epithelial cyst. But you can see how large they can be. You could also see in this case how exophytic it can be and why it can be somewhat challenging in reaching the right diagnosis. Splenic cysts can be multiple, as in this case. And again, you look at this, what else could you think about? Sarcoid, but they're a little bit lower density. Abscesses, but the patient would be febrile. And abscesses, this many, you would have to be immunosuppressed. And then usually they're smaller and hard to show fine margins. This is multiple splenic cysts. Here's another example of splenic cysts. Multiple splenic cysts, it's a leave-alone lesion. Nothing needs to be done in these patients. If the patient did have significant pain, someone would consider a splenectomy, but only because of the pain, and then it would be done laparoscopically. When you talk about cystic splenic lesions, that differential expands to epidermoid cysts, old hematoma, post-traumatic cysts, cystic degeneration of an infarct. Abscesses can be cystic, but usually not as sharply marginated. Lymphoma can be low density, can be cystic, but then the spleen will be large typically, and there will be other soft tissue findings that push you to lymphoma and not to a simple cyst, and of course metastasis. The spleen can be involved with trauma. It also can be involved with things like pancreatitis. Patients with pancreatitis, particularly repeated episodes of pancreatitis, can develop pseudocysts, and the pseudocysts track into the spleen where there's a bare area where the splenic artery and vein are, and then present with subcapsular collections. These are prone to rupture spontaneously or with mild trauma. Here's another example of that subcapsular hematoma in the spleen with a thin septation. Here's an old hematoma. Whether it's spleen, liver, kidneys, adrenals, something with dense calcification like that, rim-like calcification, it's typically an old hematoma. Could this be an old cyst? Yes, but it's a cyst that probably was a hematoma. So again, very coarse, dense calcification, easy diagnosis, hematoma. We talk about hemangiomas, most common benign lesion in the spleen. Most are incidental. You can see multiple hemangiomas or hemangiomatosis in patients with certain syndromes like Klippel-Trenaunay-Weber, Kasabach-Merritt syndrome. But again, it's unusual to see these. KTW is probably the one I've seen the most of. When we talk about some of the benign lesions like hemangioma, we go through this whole differential. You can see it's listed here in this article by Thip Haven. But again, it's not going to be a real problem when you look at the cases. So here's some examples. Splenic hemangioma. Now, we talk about hepatic hemangioma, peripheral enhancement, filling in peripheral to central. Sometimes, not that frequently, splenic hemangiomas behave just like hepatic hemangiomas. Multiple, rim enhancement, and filling in fairly quickly. That's a splenic hemangioma. And here's another one, a solitary larger one in the posterior aspect of the spleen. And here you can see it fills in fairly quickly and is bright, a splenic hemangioma. And again, here it is very nicely. Now, if you only had these images and you said, well, how do I know it's not a hepatic angiosarcoma? Well, the spleen usually would be large. You might see some stranding. You might see some infiltration. But I guess 100% I couldn't exclude that. But if I had the prior images and these images, it would be no problem. But the truth is, I still would look at this and say, yes, it's probably hemangioma. What else could it be? Angiosarcoma, which are rare. Metastasis from renal cell carcinoma. But again, then you need to see a renal cell carcinoma or a partial nephrectomy or total nephrectomy. Another example, enhancing lesion, right lobe posteriorly in the spleen. I shouldn't say right lobe, it's the spleen. One nice organ, there's the lesion. That's hemangioma. And here it is again, another case, hemangioma in the spleen. And here's again some more examples. Peripheral puddling, looking more like a classic hepatic hemangioma, but very nicely shown here that it's splenic hemangioma. Here it is on the coronal view. Here's an example with splenic hemangioma with calcification. Splenic hemangiomas rarely can calcify. If you look at this lesion, you could think of an old splenic hematoma. I could think about metastasis, but there were no other findings or no other history. But again, occasionally hemangiomas can calcify. Some of the other unusual splenic lesions beyond hematomas can calcify as well, including occasionally metastasis. In this article by Consul talking about calcified splenic lesions and a pattern approach, calcifications with hemangiomas can appear as central punctate, curvilinear or speckled in areas of thrombosis. Multi-phase CT of a splenic hemangioma will typically show a hypoattenuation of the lesion on unenhanced CT, sometimes early peripheral discontinuous enhancement with uniform delayed enhancement mirroring the blood pool, although this pattern is not always going to be the case. So we don't typically think about hemangiomas in the liver as having calcification, nor do we think about them in the spleen, but it can occur. Another example, multiple splenic lesions. Now, again, this doesn't have the look of a hamartoma, could be hemangiomas, but could be literal cell tumors. So, and even could, in theory, with the right history, be lymphoma. Here you can see a dominant mass with multiple smaller lesions. This is where hemangioma is a tough diagnosis to make without any further history, without further imaging. Here it is very nicely on the cinematic, the dominant mass and multiple smaller lesions. And again, this hemangioma, as I look at cases that can be challenging, again, this idea about angiosarcoma, metastasis. Again, angiosarcoma, the patients are febrile, the patients are sick. The patients typically have a large spleen. This is a smaller spleen. So again, washout, calcifications, there's a range of appearances. It's much easier to me to diagnose with 100% certainty in 95% of cases a hepatic hemangioma. It's more difficult with splenic hemangiomas. Though a really nice example with the vascularity, you can see it on the cinematic, but again, you would think about metastasis. You might think of melanoma, you might think of renal cell carcinoma. So it's not going to be a perfect diagnosis. I mentioned multiple hemangiomas and some syndromes. This is Klippel-Trenaunay-Weber, which also gives you soft tissue hemangiomas. Now, a lesion that occurs and is often confused with malignancy, but I think most of the time I can make the diagnosis with certainty, like 100% certainty, is hamartomas. They're rare, can occur at any age. usually solitary but can be multiple, and can be associated with tuberous sclerosis. Women are more likely to present with symptomatic larger lesions. Rarely hematologic disorders, including pancytopenia, anemia, or thrombocytopenia, can occur from sequestration. Splenic hamartomas have been associated with other hamartomous entities like tuberous sclerosis, but I would say most of the time a hamartoma is an incidental isodense or hypodense lesion on non-contrast CT with enhancement after IV contrast. You could have a difficulty separating from hemangioma. I think the difference is, if you look at this case non-contrast, see how it's bulging outside the liver, and you see how well defined it is on venous phase imaging. The bulging, to me, is hamartoma. Just the way it's well defined and sharply marginated. Here again, it's exophytic, well-defined bulging. There's some enhancement, but that's also a hamartoma. Just like I showed you some different enhancements in hemangiomas, this is more of a vascular hamartoma. The prior case wasn't. And you could see as you carry this out a bit further, the vascularity washes out. But again, to me, it's that bulge, the way the lesion looks, that really pushes me to hamartoma. Another example, again, this mass coming and pushing outside the splenic border, pushing as it often does on the stomach. But again, this mottled vascularity, could you be thinking about some malignancy? I guess the answer is yes, and I've been referred many patients with splenic hamartomas who are felt to be splenic lymphoma or some other malignancy, and then we talk about that this is going to be a hamartoma. Sometimes patients end up with surgery because the surgeons are not convinced and the patient's not convinced. Most of the time we can prevent further intervention. Another example, there is that bulging of the lesion forward, some enhancement present. A nice example, and a few more images of the splenic hamartoma. And again, these are larger lesions. We saw a couple larger hemangiomas, but hamartomas usually are larger. That 5 to 8 centimeter range is very common to me. And here's how it looks texturally on the patient's imaging with cinematic rendering. And again, this article by Tip Havang, splenic hamartomas are tumors composed of a varying mixture of tumor tissue and normal splenic tissue, ranging from a few millimeters to 20 centimeters. Splenic hamartomas can be associated with syndromes, tuberous sclerosis, and Wiskott-Aldrich syndrome. Again, those syndromes are rare. I've seen a few cases of tuberous sclerosis, or actually a number of cases, but then I'm looking usually at the kidneys for AML, and I'm not seeing these splenic lesions. And again, going backwards, hamartomas, isodense or hypodense on non-contrast scans. Again, the vascularity, this contour abnormality, that bulging out, to me is going to be the most helpful sign. Calcification, cystic changes, and fat can be seen, but I think that typically doesn't help me in my diagnosis. Now, there are a number of other unusual benign splenic lesions, including literal cell splenic angioma. That's just a mouthful. But let's do this. We've gone on for almost 20 minutes. Let's take a break, come back, and let's pick up right here. See you in a few minutes, everybody. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.